tonight we are going to be talking about the development dysplasia of the hip, or the DDH. And I'll start with a brief overview. By definition, DDH is underdevelopment of the acetabular compartment of the hip. That means a shallow acetabulum with or without subluxation of the femoral head, and it can be accompanied with a secondary hypoplasia of the femoral head. I must state that before it used to be called congenital dysplasias of the hip, but because it was realized that actually the problem is not always congenital. Some children really develop the issue later on, and it wasn't congenital. So that's why they changed the name from the congenital dysplasia of the hip to developmental dysplasia of the hip. So it affects about 1 to 3 infants in every 1,000 births, and is more common in the female than the males, with the ratio of about 4 to 1. And the left hip is more affected than the right hip. That's 3 times more prone to getting the DDH than the right hip, and the reason is most children that are in the cephalic presentation in utero are usually in the left occipital anterior position, and that puts the left hip against the maternal spine, and that limits its movements. And in some cases, it can be bilateral, though it is mostly unilateral, but it can be bilateral in about 20% of the cases. And the first 6 months a window where it is easy to treat this disease, the dysplasia, in case it is identified quickly. But the most ideal time to identify this issue is about 6 weeks of life, postnatal life. And mostly we use ultrasound before 6 months of age. Reason is after 6 months, we get the femoral head starting to ossify, and of course we know ossification and the ultrasound attenuation. So assuming the dysplasia is not diagnosed early on in life, what will happen? We'll get sometimes the end result is, excuse my background noise, I'm still at work. So the end result.
Sorry, may I just disturb you? You are not sharing your screen. Had you noticed?
Well, I thought I was. Screen. All right, let me just do it. Sorry.
Still not yet sharing.
It's disabled by the host. Maybe you can give me the rights.
You did. Okay, let me just cross-check there.
Yeah. I hope you can see the screen now. Can you see my screen now? Hello?
Yes, we can see the screen now.
Okay,
yes,
should I just continue from here? Okay, I'll just continue from here. The natural history, assuming the DDH is not detected early on and it's not managed early on, Okay, my screen. I think you should make me a co-host so that I don't get to lose my screen always. Yeah, sorry about that. So as talking about the natural history of VDH, assuming it's not detected early on and managed, a child can have a painless limp or unilateral toe walking. Sometimes even when they're crawling, you can see that one leg is just lagging behind. And of course, there are other causes of such gait, and we have cerebral palsy and peripheral neuropathies can also cause that painless limp. And with time, the child or the teenager can develop stiffness in the joint that's been affected, and sometimes they get the Trendelenburg stance. The the drawing on the side here shows how the Trendelenburg how the stance looks like in the normal hip. When you're walking and the leg that is standing down, usually at the waist level tends to go, the forces pull it down so that it can balance this other leg that is up, and the waistline goes up on the side that is in the air. However, in the Trendelenburg stance, it will be the opposite, and this is usually due to a weakness in the gluteus medius and the gluteus minimus muscles. Sometimes can be due to an injury to the superior gluteal nerve, though it can also be due to DDH. So I put these other causes just for you to be aware, not to see that every person has a Trendelenburg stance probably has DDH that went unrecognized. It can be due to other reasons. And as the child goes on, or as the person goes on in life, they get a decrease in speed and endurance in that very limb, the affected limb, and the ultimate end result of all this is arthritis. And that is the very thing we don't want to happen in these joints. And that's why we need to identify them early on and treat them quickly. So a brief look at the anatomy of the hip, considering the pediatric hip, because this is what we are talking about mainly. We have the three bones, the ilium, the ischium, and the pubis that are joining at the triradiate cartilage with the femoral head, and then we have the cartilaginous part of the acetabulum and the labrum laterally, and on the side we have our gluteal muscles, the gluteus minimus, medius, and the maximus. And when we look further at that joint, inside the joint we have a synovial cavity, of course, with synovial fluid, because we know this is a ball and the socket joint and synovial. So our acetabulum is forming the socket, and femoral head is definitely the head. So we have the ligament of the head of the femur inside the joint. We have the acetabular labrum still. We have our cartilage. So what happens when the hips are developing? It is very necessary for this femoral head to be centered in the middle of the acetabulum, because it gives it stimulus to grow and to become deeper, the acetabular fossa to become deeper. So what happens if this head is not sitting well into the acetabulum? The acetabular labrum and the cartilage and even this ligament of the head of the femur, they will hypertrophy, plus there is some fibrofatty tissue in the joint that is called the pulvina. They will hypertrophy, and when they hypertrophy, they'll make it hard for this joint to move as it ought to move, and that's when the patient ends up with altered gait. So before the advent of X-rays and ultrasound, of course, these cases were being seen, and the pediatricians mainly were using physical exams to try to see or to detect children and infants who are at risk or had the DGH actually. So the physical exams, we can look for asymmetrical skin folds, I mean the gluteal folds. When you look at the gluteal folds, they may be asymmetrical. There might be a shortening of the femur, the so-called Gallia's sign. Like if the child lies supine and then they flex their knees 90 degrees, you will notice that the knees are not at the same level. The affected knee will be will be at a lower level than the normal knee. And then you might find limited abduction of the hip joint. It will be around less than 70 degrees. And that is because of the pulvinar and teres ligament that I talked of and the labrum that hypertrophy and occupy the socket that ought to be filled by the femoral head. And when you see in the normal babies, there's always that mild knee and hip flexion. So in cases with DDH, that flexion is always lost, the mild flexion at the knee and the hip. And then there is the Ortolan test and the Barrow tests that are usually used in the newborns. With the Ortolani, actually we shall start with the Barrow. The child is lying supine and the doctor holds the child's knees and tries to dislocate the hip actually by pushing the femur posteriorly and adducting the limb. That way, the force applied will force the head out of the acetabulum. And of course, these babies, when they're newborn, the ligaments are laxed because of the effect of the estrogen, and they can be dislocated. And the Ortolani is the reverse, where they try to reduce the dislocation by abducting the hip joint and then pushing, trying to translate the femur anteriorly. And this test, because of the effects of the estrogen on the laxity of the ligaments wanes off with time, these tests are less sensitive after around 2 to 3 months because the hip capsule is also tightening. And some literature used talk of asymmetrical inguinal folds, and they said it's not really sensitive. Excuse me. Reason is because they see asymmetrical inguinal folds in about 30% of children with normal hips, and in all cases of DDH, we don't have asymmetrical inguinal folds. So it is stated in some literature, but it's not really that specific or sensitive. So the indications for imaging, after these pediatricians have excuse me, have screened these infants or newborns, and then they find an abnormal physical exam, they can send them for imaging. Or even if the exam is normal, but the newborns or infants have risk factors for DDH, they can be sent. Excuse me. They can be sent for radiological investigations, and mostly we use either plain X-ray or we use ultrasound depending on the age of the patient. And of course, the risk factors, we know the 3 most biggest risk factors is female sex, where we said that the females are 4 times more prone to getting DDH than the males. Of course, in the left hip, we got the reason is because of the left occipital anterior position in neutral. And then we have the family history. If you have a first-degree relative, say a parent or a sister or brother who has DDH, then your chances of getting DDH are also increased. And then breech presentation in utero, because in breech presentation, most times we have the babies having their hips that is extended, so they tend to pull the femoral heads out of the joints. And of course, first child is also considered one of the risk factors. Some sources say it doesn't really so much affect, but yes, the first 4 Fs, they had the female family history, first child, and feet first, which is the breech presentation. And of course, other causes extrauterine, we have the swaddling, like this image here is an image of a baby that was swaddled in the Asian part of the world. They usually have what they call the swaddle boards, where they, as you can see, the baby is held, kept sexually into that swaddle board. But the problem with this is when you look at the baby's hips, they're really straight, or should we say they have been adducted and they have been extended. So the force applied to the hip joint literally pulls the head out of the acetabulum. And remember, we said the DDH is not congenital. You can be born with literally normal or would be normal hips, but because of such practices, the femoral head is not centered well in the acetabulum, and you not stimulate the acetabulum to grow to the acceptable depth for you to have a normal hip later on in life. So such practices are really discouraged. Thankfully, in the African part of the world, I'm not so sure, but I don't think we don't usually swaddle our babies like this. And of course, in utero, oligohydramnios, still for the very reason of reduced baby movements because of the oligohydramnios. And the DDH has also been associated with cases of congenital torticollis and foot abnormalities. And also myelomeningosis mostly at the levels of L1 to L3, though literature also says it's not so much associated with the DDH. So here I just put images of how probably in different cultures we carry our babies. And in the first image, this is typical of here in Uganda, mostly now in our villages. Of course, with civilization, we have gone on changing. But this is good because you see the baby's hips are not really straight. They are somehow flexed at an angle and even abducted. So that really keeps the femoral head in position. And that is a good thing. In the second image, same thing, good position of the baby. And then this third image, we see same person carrying the same baby, but in two different positions. So I know with civilization now we use these carrier bags, but you should make sure in this first image, you see the baby's hips are straight. Or should we say they're close to being abducted? When you see the mechanics really to pull the femoral head out of the acetabulum laterally. And this is not good if you're going to carry this baby for like 2 hours like this or an hour. It won't be good for the child's acetabulum, and definitely this child will be at risk of getting DDH, not because the child was born with it, but because of the extrauterine factors. So carrying the baby this way would be a very, very good way, very good for the baby's hips, and of course, life future ahead. So imaging. They started with plain radiography before, of course, the advent of ultrasound, and plain X-ray is so good after 6 months of life. Why? Because we have our femoral heads ossifying at around after 6 months. A little earlier on in ladies, in females, that's between 3 to 6 months, and later on in males, 4 to 7 months. And we use the AP view supine with hips in the neutral position. And of course, when you're looking at the AP, or when you're looking at the radiograph, certain landmarks that help us to see whether the hips are normal or dysplastic. And we have the Hilgenreiner line, that is a line drawn horizontally through the triradiate cartilages on both sides. And we have the Parkins line, that's a line drawn from the lateral margin of the acetabulum that is perpendicular to the Hilgenreiner line. And then we have the Shenton lines. Shenton line, that's a line, an arc kind of, it's drawn in the undersurface of the femoral neck that should be continuous with that of the pubis. So what are the signs of dysplastic hip on plain X-ray? Of course, we shall have a disruption in the Shenton line. In this very diagram, we see this the right side is normal. You can see an arc drawn swiftly under that undersurface. And on the left, you have a dysplastic hip. You can see this arc is broken. It's not really continuous. So this is a sign of the DDH. And then you have a decreased femoral head coverage. Decreased femoral head. The femoral head should ideally be in the acetabulum, but because this hip is dysplastic and the head has been displaced laterally, it's mostly superior posterior displacement. Excuse me. When you draw your Hilgenreiner and the Parkins line, you find that the normal head should be found in this the inner lower quadrant of that intersection. So in this, you see that the head has been displaced laterally, and we are seeing it in the upper lateral quadrant. And you can see the space really here is increased compared to this. That's also a sign, and we have the acetabular index. The acetabular index is literally an angle that when you draw a line from the inferomedial aspect of the acetabulum to the superolateral aspect of the acetabulum, and you draw a line that is coming to join the heel general line, the angle that is made between there is what we call the acetabular index, and it should be less than 30 degrees in these infants. Of course, it's bigger at birth and goes on reducing with age. And at around 1 year, it should not go beyond 22. So you see on this normal side, the angle was 21, and on the side was 40. That's also an indication of a dysplastic hip. And as we said before, the DDH can happen with or without the delay in the ossification of the femoral head. Of course, when you do your X-ray, if the baby is above 6 months, or if you do an X-ray and then you can see the femoral head ossification starting on one side, but on the other side it's not seen, that can also be a sign, the delayed ossification. And we have the teardrop sign that is formed by there's a ridge as you age. There's a ridge that comes at the floor of the acetabulum, and that ridge, when you see mostly in the adult pelvic X-rays, there is that so-called teardrop, the structure that is around here, a teardrop. So that teardrop, when it becomes wider than normal, it can be a sign of acetabular dysplasia. It is not so specific, or it can be a sign of joint effusion. And when it is narrow, it means the acetabular fossa is deeper than normal. So here, an example of a pelvic X-ray of a child. We can see the normal hip on the right, and we can see the dislocated hip on the left. So the femoral head has started to ossify. If you see at that point, we see it ossified. Even this side, it is ossified. But even if it were not ossified and you project, the femoral head would be ideally in this lower inner quadrant, unlike on the affected side where we have dysplasia. You can see it is in the upper outer quadrant. And then you look at the Shenton lines, they're really this on the normal hip, it is a smooth arc. And then on the dysplastic hip, it is a discontinuous line. Of the same another image of the same case, normal right, abnormal left. If you try to visually draw that line, the Parkins line going down, and then the heel general line, you will see that this is really in the upper outer quadrant. And if you try to draw your Shenton line here, it breaks here and then comes back here. So it can't really give you that nice arc like on this other side. So that is how the X-ray would help us to diagnose. And another sign that I didn't really get a good image for, but in these dysplastic hips where we even have some ossification of the femoral head, you see that this hip, this head will be touching this part of the iliac bone. And remember, we said where the bone, where the head touches, it will stimulate creation of a fossa. So we can get a pseudoacetabulum at around this area because the head is there in contact with this part, and instead of having this true acetabular fossa developing here, it will be underdeveloped, and then you have something like a secondary acetabulum, or the so-called pseudoacetabulum. And of course, it makes issues worse because this acetabulum was already inadequate, but the size of the inadequacy is being increased by the pseudoacetabulum. And with age, because of the friction, the osteoarthritis can develop very early in such a hip with a pseudoacetabulum than a dysplastic hip without a pseudoacetabulum. So really, early diagnosis and management are very crucial for a better quality of life. So when we come to ultrasound, of course, we usually use it. Before the first 6 months of life. Why? Is because we are avoiding to go in when the femoral head has ossified. And in some countries, mostly in Europe, they screen all all babies. As long as you're born in some of those countries in Europe, they have to screen you for DDH. And of course, the screening for all has been controversial, and it's not the standard for all countries. Every country adapts its own practice depending on the evidence they find. And the reason why the people who support screening for all babies want every baby born screened is because they say it increases the detection rate of abnormal hips. Of course, the abnormality, as we saw, can range from a mild instability to the dislocation. It's a whole spectrum of various degrees of the DDH. And though there's no evidence of significantly reducing the late diagnosis of DDH with screening of all babies, and that's one of the reasons why people who don't want screening of all babies don't want. They say because even if you screen all babies, some may be diagnosed late. So why if they don't have risk factors, why should they be screened? And of course, the other reason is when you screen all, you can have some false positives. And when you have false positives, say in physiologically immature hips, you have that joint laxity. Of course, you increase the risk of overtreatment. And when you overtreat, the commonly used treatment is bracing, mostly using the public hands brace. And one of the problems that arises from too much use of unnecessary use of the public hands, we can get a vascular necrosis of the femoral head. Of course, we know that is very detrimental, usually due to a forced abduction. We shall see how the public hands is applied. You see the hips are abducted. So when you forcefully abduct them, the femoral head might lose blood supply, and of course, you don't want that to be happening. And sometimes in some children, you can have the femoral nerve palsy due to the hyperflexion, and also the pelvic disease. The pelvic disease is something similar to creating a pseudoacetabulum. So because of such reasons, some people said no, they shall be going for the selective screening. And the selective screening is if a newborn has an abnormal physical exam, or if they have risk factors that we saw before, then they'll go on and then screen them with ultrasound. And when they say some countries, of course, this down here is not universal. It really depends on your department and the country you're coming from or where you're practicing. Those who prefer selective screening, they say when you're newborn and you've been born in breech, but you have a normal physical exam, they'll still check you for ultrasound at around 6 weeks. If you're a newborn and you have abnormal physical exam, they'll do the ultrasound immediately to establish the baseline, initiate your treatment, that is the bracing, and then start serial scans at around 4 to 8 weeks interval between the exams, depending. And why are we doing the ultrasound in the developmental dysplasias of the hip? There are basically 3 questions that we want to answer. And the first question is the ball, which is the head of the femur, is it in the socket, which is the acetabulum? That is it located or is it dislocated? And on maneuvering or on applying stress, does the ball stay in the socket? Is the joint stable or it is lax? And the other question is the socket well formed? Meaning is the socket is the acetabulum, is it mature? Does it have adequate depth or it is dysplastic? And with ultrasound, of course, we use the linear high frequency probes. The baby is either in supine or the lateral decubitus position, whatever is easy for you. And different methods of evaluation have been proposed. There is a school that goes with the Graphs method, that is the most common. And the Graphs method usually assesses the morphology of the anatomy or the anatomy of the hip joint using coronal imaging. And then we have the acetabular or femoral head coverage that is assessed using what we call the Tagesson method or the Morin-Tagesson method. And then there's also the Harkis method that is used to evaluate for the dynamics or the mobility or the stability of the joint. And the graph usually uses coronal imaging, but they can also obtain images in the transverse. And then the Tagesson also uses a coronal plane, and the Harkis uses the coronal and also the transverse imaging with or without stress, and either with the hip in neutral position for inflection. So we will start with the graph method. So graph proposed a grading for the DGH, the dysplasias of the hip, from the normal to the totally dislocated hip. And he uses, as we said, the longitudinal or the coronal view to obtain a view that they call an egg in spoon view. And of course, to him, this is the most important, and you should have the hip flexed at around 20 degrees. And that is in a newborn, that's around the normal position, or the so-called neutral position of the hip. And when you do that, the image you get should look like this. We have this is the ilium, or the contour of the ilium, and it should be as horizontal as possible. You manipulate your probe until, actually, when you put your probe in the coronal in the coronal plane on the side of the baby's hip, you try to angle it about 10-15 degrees posteriorly, with the caudal end around 10-15 degrees posteriorly, and you maintain the posterior end of the probe in the midline. And you should get something similar to this, the horizontal contour of the iliac bone, and then you have the roof of the acetabulum. That should be nice, and you have the edge or the rim that should be the ilium where it is transitioning into the roof. That angle should be prominent, a nice one in a mature hip. And then you should see the pubis, you should see the triradiate cartilage that appears hypoechoic, and then there's some fibrofatty tissue or the pulvinar, and the ligament of the femoral head, what we saw, the ligamentum teres. And of course, this is the femoral head. The femoral head, because it has not yet ossified, we see it as a hypoechoic structure with those spects, the hypoechoic linear strands, because it is mostly cartilaginous. And you should be able to see the labrum that is labeled here L. And then this asterisk shows the cartilaginous part of the acetabulum. You can see the femoral head, the delineation of the femoral head is here. Between the femoral head and bone roof, we have that cartilage. And of course, we have our muscles here, the gluteus minimus, the medius, and then also here, also the tensor fasciae latae was shown. So ideally, when you get your probe right, an image like this or close to this should be seen. And as we said, the true coronal image should contain all that we've just been mentioning. And on the graph method really relies on angles, because we are looking at morphology. And he has three lines that we should use. There's the base or the iliac line. This is a straight line that goes along the contour of the ilium. So this is the reason why we need our ilium as straight, as horizontal as possible, so that you can have where to draw that line. When you go to your machine and you go into orthopedics, we have that information there. You can easily draw the lines. And then we have the bony or the acetabular roof line. It goes from this angle down to the roof, along the roof of the acetabulum. And then we have the third line, which is the cartilaginous roof or the labrum line, also moves from this promontory to the labrum, through the labrum. So those are the three lines. And the angle created between the baseline or the iliac line and the bony roof line, what others call the bony angle, it's actually what we call the alpha angle. And in a normal hip, it shouldn't be greater, it should be above 60 degrees. And the beta angle, which is the angle between the baseline and labrum, the labrum line, it should be less than 55 degrees in the normal hip. So graph uses basically that to see whether the hip is normal or abnormal, and then he grades the hip abnormality according to the angles. So we shall see in the normal findings. Of course, we said we have the good definition of the bony rim. The bony rim is that the promontory, that angular edge of the acetabulum or of the ilium of the iliac bone, that edge in a mature hip should be angular. It should have an angle. It shouldn't be rounded. It shouldn't be flat. But of course, we shall see in the different grades. And then we have an undisplaced cartilaginous roof triangle. If I go back this image, we have this triangle here formed by the labrum, and then of course we have the cartilage. This triangle should not be displaced, this hyperechoic triangle that you see. It should be covering the femoral head as seen here. If it is inverted, pushed upwards, or if it is inverted, pushed inwards between the femoral head and the acetabular roof, definitely we know there is a problem. And the femoral head should be well covered within the acetabular fossa. Well, according to graph, for you to say that the femoral head is well covered within the acetabular fossa, the alpha angle should be above 60 degrees. And the bony angle, which is the alpha, should be above 60 degrees, and the cartilaginous angle, which is the beta angle, should be less than 55 degrees. So, sorry. Okay. Sorry about that. So, the classification for the graph classification, it classified the dysplastic hip into four categories. There is the class 1, which is the normal hip, the mature hip, which has an alpha angle of greater than 60 and a beta angle of less than 55, have normal bone rim, it is mature, and it is not, the labrum is not inverted. And then you have class B or type 2, which was further classified in 2A, 2B, 2C, depending on the angle we see here. In 2A, we have an alpha angle that is reduced, that's between 50 and 60, and an increased beta angle that can be anywhere between 55 and 77. But if this baby is less than 3 months of age, then we can take that as physiological immaturity of the hip. So there's no need to worry so much, but of course you need to follow up this hip and see it can stabilize with time. But if you get the same angles and the baby is above 3 months of age, then he classified that as a class 2B. And in 2C, we have an angle, alpha angle, going on to reduce. It's now between 43 and 49, with now a beta angle that is greater than 77. The beta angle has increased. So you say as the alpha angle is decreasing, the beta angle is, as the alpha is decreasing, the beta angle is increasing. And in 2C, we have acetabular deficiency. In 2D, you have still the same angles. The difference is with the labrum. The labrum is inverted in 2D, unlike in 2C, the labrum is fine, but there is acetabular deficiency. So, and then in class type 3DGH, you have an angle that is less alpha angle less than 43, beta above 77, and there's also inversion of the labrum. And in type 4, you have the alpha angle is really unmeasurable, and the hip is really dislocated. That's the worst case of DGH. So we have here schematic examples. We see in the first type 1, you can see the angle is fine. Your promontory, when you try to relate with the sonogram, this area here is the iliac bone. So the ilium, where you're drawing a baseline, will be along this border coming downward. And then you draw your roof line from here, the promontory to the bone roof, which will be around here before the ischium. And we see our labrum covering the femoral head very well. The capsule is covering, and the cartilage is covering the femoral head well. As you go on to type 2, type 3, type 4, you see that the promontory loses the angular shape and it starts being rounding off, and here it is completely rounded. And then you have, because the femoral head is now more lateral, this labrum, which should have been on the lateral aspect of the femoral head, is now on the medial aspect. So it is either inverted or everted. And really the roof is very poor and the hip is really dislocated. And after Graf proposed that kind of grading, it was modified later on with time. And of course, we still remain with 4 types. This time they are broken down a little more. So type 1, of course, is still the mature hip. The bony roof is good. You have an alpha angle greater than 60. The bony rim or that angle is sharp. And then you have a good coverage of the femoral head by the cartilage. But it was further subdivided into 1A and 1B, with 1A having, excuse me, and 1A having a beta angle of less than 55 degrees and 1B having an alpha, a beta angle, sorry, of greater than 55 degrees. And this classification applies for any baby seen for ultrasound regardless of the age. And in the type 2, remember we had type 2A, B, C, and D, but here the A was further classified into A plus and A minus. And in the A plus, you have an immature but appropriate for age. The maturity is logically immature, but it is appropriate for the age. The bony roof is adequate, and you have the bony angle a little reduced, between 50 to 59. And instead of the sharp bony rim, the promontory is now blunt, but the femoral head is still well within the acetabular. And this baby is less than 3 months. And this is what we call the physiological immaturity. And this is fine. And then here we have the type 2A minus. Same, but the bony roof is somehow deficient. When you do a scan, you don't see that echogenic roof, but the angle is still the same. And the bony rim, instead of being blunt, it's now starting to round off. It's a little rounded, but still the femoral head is still within, is well covered by the cartilage roof. And this baby is still less than 3 months. So in type 2, there's delay in maturity of the hip joint because there's a deficiency in the bony roof, and then you have the alpha angle still the same like in type A, and then the angle or the bony rim this time is also still rounded, but the femoral head is still within, the bony head is still within the well covered by the cartilage, and this baby is about 3 months. So this baby, ideally, type 2B would be followed up with serial exams to see whether the hip is getting better or it's getting worse. And then the type C, it's the maturity is either stable. The hip is either stable or unstable, but it has a severely deficient bony roof, and the alpha angle has reduced. It's between 43 and 49, and the bony rim or the promontory might be rounded or flat, and but there is still coverage of the femoral head, and the beta angle is less than 77 degrees, and this is independent of the age of presentation. Whether the baby comes less than 3 months, and then you see this, it is regardless of the age of presentation, unlike type 2A and type 2B. And then the type D or the type 2D, you have a decentering hip. Basically, the femoral head is known to well within the acetabular fossa, and the bony roof is really severely deficient. The angle is close. It's the same as that in type C, and still the promontory is the same, rounded or flat. But the difference between type 2C and 2D is here you have nice coverage of the cartilage roof, but here the cartilage roof is displaced, and then the beta angle is also greater than 77, unlike in type 2C where it is less than 77 degrees, and this is also for all ages. And then type 3 is an eccentric hip. It is not well centered, and the bony roof is really poor. You have an angle less than 43. The bony rim is flat, and the labrum has been pressed upwards by the decentered femoral head. It's also for all ages. And the type 4, the worst one, we have still the femoral head is eccentric. It is off center, and the bony roof is very poor because the femoral head is not within the acetabular, so there's no stimulus for growth. The angle is also less than 43, and the bone rim is flat and the labrum is pressed downwards. So you know the difference in type 3 and type 4 is about the labrum. So you see how important it is for you to get the true coronal image so that you can see your labrum. If the labrum is pressed upwards, it's a type 3. If it's pressed inwards, it's a type 4. So that's the modified graph. And here an image just to show the angles. We have here a mature hip. We have our iliac bone, straight horizontal outline. We have our angle or the rim sharp. We have the roof is mature, and then you can see our the ischium down here. We see our labrum covering the cartilaginous labrum covering the femoral head, nice and smoothly. And of course, when you draw your angles here, the alpha angle was 64 degrees. So this is a normal hip. Compared or contrasted to this image where we have still a straight iliac bone, but the labrum is not really displaced, but we can see the edge or the rim of the acetabulum is not as prominent as this one here, and our roof this is not yet deficient, but when you take the angles, you really see even the head is a little. By this baseline, you can see visually that most of the head is out of the acetabulum. And when you look closely down here above the ischium, you see the fibrofatty tissue. As you get more and more displacement or dislocation or subluxation of the femoral head, the fibrofatty tissue and the ligamentum teres, they hypertrophy, and you might see hyperchoic substance filling the acetabulum. And when the more it hypertrophies, the less likely it makes it easy for the treatment to work. So translating into complications later on in life. So of course here the angle was not noted, but when you look at that angle, in case we had the figure of the angle, and then you look at the bone roof, you look at the rim, you look at the coverage and the displacement and all that, and the labrum, you would go back and to the other table and try to know which type of graph grade you're dealing with. So this is still another image from krishnanatrasoundimages.com. This was graded type 2C DDH. We see our ischium not as horizontal as it should have been, but yes, it can work. You can still get your angles. And then you see the acetabular roof is really deficient. It is this echogenic outline of the acetabular roof ought to have come all the way down up around here to the triradiate cartilage. But you see the ischium is here, then there is no acetabular roof. But of course, you see this, the femoral head is still in the center, though the alpha angle is really reduced, about 45, and the beta angle is somehow 52. And you see this echogenic material, the pulvina, filling this space between the ischium and the femoral head, because the head is not well deep into the acetabular fossa. And these are two examples of grade 4 dysplasia according to the graph classification. You see our labrum here that was initially going up to around here of the femoral head. It's now pushed, compressed around here. We see our rim is kind of flat. You see the echogenic material here posterior to the femoral head, very thickened. That's the pulvina. And of course, when you see these chances of using bracing to reduce this hip really minimal, probably more invasive treatment will probably be needed for this infant. And same here, you see this the roof in the acetabulum is really deficient, and the rim is kind of flat. It's not angled as a normal hip should be or ought to be, and even the labrum is pushed a little, and the femoral head is really out. If you try to draw your angles along these images, you really see that the alpha angle is really small and the beta angle will be too huge. And that shows that really the head is really out of the acetabulum. So another similar image, of course, similar findings. This one was already on treatment, was in a harness. This was a follow-up, trying to follow up the DGH, and it's true, see that echogenic pulvina filling up the acetabular fossa, and the hip is really immature. The rim is not that sharp or angular. So that is really about it, about the graph grading. Graph was just looking at the morphology using angles, and then you grade as seen in the table before. And now Hack said no. He wanted to classify the stability of the hip and see, is the hip, you might see a hip well placed in the coronal plane, but when it is unstable, when you apply stress, it will get out of the acetabulum. So he wanted to further go on and classify the hip stability. So he uses literally the same technique using supine or the lateral decubitus, probe still over the lateral aspect of the hip, and then he starts still with the coronal images, just as graph, with the hip in neutral, and then with the hip inflection of around 90 degrees. He also sometimes adds on the posterior lip view. We shall see that. Excuse me. And then after the coronal images, you go on in the Hack method to use the transverse images or the transverse plane to scan the hip still in the flexed position and with passive abduction and adduction of the hip, with and without stress. So the stress here is used, or the stress, what we are doing, we are applying the Otolani and the Barlow tests that we talked of before. So he wanted to simulate the clinical exam, the clinical physical exam that is done by the pediatricians, try to simulate that on ultrasound and try to see, is the hip moving, is it dislocatable, is it subluxable, and is it reducible after dislocation? So that's why we apply the stress. And in the normal hack method, if we are to see the transverse image, I'll first show you a diagram that I drew up myself because I failed to get appropriate images online. So if you do the transverse kind of image, the acetabulum should give you that nice kind of U shape. You have this lip being the metaphysis of the femur, with the femoral head definitely attached to the metaphysis, and it is appearing to be like an egg in a cup, kind of. And then this other side is the ischium, and of course the thyroidal cartilage will be below. So on a transverse image, you should get something like this. But when there is subluxation, when you apply your stress, the U shape or the U configuration will change from the U to the kind of V configuration, because now imagine your force is coming from your left side of the screen towards the right. You're applying your Barlow, and then you push, because there's laxity of the joint capsule. This head will slide, since this ischium is a fixed structure, so it will slide and go upward together with the metaphysis, and then to give you that kind of V-shape, because now this one has moved upward. And in case it is dislocatable, it will even go further on up till like around the top of this, and then you get that L kind of configuration of the hip on the ultrasound image. In the transverse view, as we said, the triradiate cartilage should be seen centrally at the bottom of the image. So it would be around here. Remember, the cartilage is hypoechoic, so it would be this middle image is an image I got an annotated image from the internet, so it should be something like this. And then we have the metaphysis of the femur, this echogenic line giving us a shadow, and of course this is the femoral shaft, and we have our ischium on the other side, and we have the labrum here. And these are the gluteal muscles, still minimus, medius, and the maximus. So you should have that kind of nice U shape. Even when you apply stress, that shape should remain. It should not disconfigure into the V or the L shape. So that is And he says there should be no displacement with stress, definitely, because he's basically trying to look at stability of the joint. And in case you have a displacement greater than 4 millimeters between the acetabulum and the femoral head, that signifies instability. So remember, acetabulum is being formed by part of the ischium. So in case you apply stress and then this femoral head goes a little bit out, kind of up, or seeing these images, of course, this would be like the flow of the acetabulum or the medial part of the acetabulum, the acetabular fossa, I mean. So if you apply stress and then you push this head and it goes up, and there's a distance from the medial end of the femoral head to the base of the ischium that is greater than 4 millimeters, then they consider that that hip is considered to be unstable. So this is the normal transverse I got online, and of course, as I was preparing this presentation, I wanted to get some images as well, and this was the kind of shape I got for the right hip. We see our though my image is flipped, it's not like this one. My femoral metaphysis is on this side, and of course the shaft going that way, and the ischium. But you can see the nice U shape and the femoral head well centered. And on the left, still the same. Down here, they applied stress, but still there's no change in the configuration of the image, meaning that this hip was stable. And this was the coronal view. How we tell it is coronal, you can see it does not have that U kind of shape, but has that straight ilium. Then it has a nice roof. See the femoral head, you see the metaphysis and the femoral shaft starting there, or the ossification creating that shadow, and the ischium below. And of course, we don't see much pulvina here, meaning it's really the normal hip. So we've talked about the U. The U configuration is the normal hip on stress on transverse view using the Hack evaluation. When you have subluxation, it transforms from the U to the V. With this location, it will come from the V configuration straight to the L, because the head is now literally moving over the ischium, and of course the part of the ischium that will be seen will be here. That's why you see the femoral head on top of the ischium with that L configuration. So another image of the internet image, not my personal work, of an abnormal hip. This was on a transverse without stress. You see the metaphysis of the femur, and then the shaft. We have our head nicely in the acetabulum, but when the stress was applied, you see this is the shaft. Remember, the force is coming from this direction, pushing upwards. So we find our femoral head is really pushed out of the acetabulum. You have that distance that is increased. Our ischium is down here, so this will signify that the hip is dislocated, because it has come from the nice U configuration to the L configuration. So this knee was dislocated, and definitely this patient had to be initiated on treatment. Good enough when you go, given the no ossification of the femoral head, we can well be sure this child is less than 6 months, and of course bracing would work perfectly to avoid complications later on in life. So Hack defined capsular laxity as when you're having more than 50% of the bone coverage. The femoral head is covered very well, more than 50% is covered. Of course, he also uses the coronal image here to see that the head is covered, like what percentage of the head is within the fossa. So when you have this coronal image and more than 50% of your head is within the acetabular fossa at rest, but when you apply stress, you have less than 50% of the femoral head within the acetabulum, then that is considered capsular laxity. That can happen due to the physiological immaturity. It can happen due to mild form of dysplasia, depending on what age the patient is at. And then he defines subluxation as having less than 50% of the bone coverage at rest. So you've not applied stress, but you have your femoral head covered less than 50% in the acetabular fossa. That is subluxation. And in this location, the femoral head is lying completely outside of the bony acetabulum at rest. So that's how you classify. And then we talked of the posterior lip view. In the posterior lip view, still you have your ilium in view, you have the ischium in view, but you've moved your probe a little more posteriorly. And at that level, we are seeing that this is still the triradiate cartilage, the hypoechoic, but you're seeing where it is joining the ilium is joining the ischium, that at the triradiate cartilage. And in this view, the femoral head should not be seen anywhere. But in cases of dislocation, you might do your coronals and you can't see the head anywhere in the acetabular fossa. When you go posteriorly, you find the head, it will be sitting nicely over this area here, over the triradiate cartilage in this area. So when you see that, that is really total displacement or dislocation, sorry, that graph would call type 4. And the posterior lip, when normal, would look something like this. And the other method we talked of the femoral head coverage, or the Tadjesen or the Morin Tadjesen kind of evaluation of the hip. This Tadjesen and Morin intended to see whether the acetabular fossa is adequate, whether it is deep enough or whether it is shallow. And for them, they use the coronal image, and they try to measure if you have greater than 50% of coverage of the femoral head within the acetabular fossa, they consider that as a normal hip. And in case you have less than 50% coverage of the femoral head within the acetabulum, then that is abnormal. They will say that's an abnormal hip. And of course, some proposed a cutoff of around 47% coverage in males and 44% coverage in females. But generally speaking, less than 50% coverage would be an inadequate acetabular depth. So there will be dysplasia of some sorts. So this is the coronal image as we saw. We have our ilium here, nice horizontally displayed. You have the femoral head within the fossa, and we have the bony roof. We have our rim. This is really a mature hip. You can see the rim is angular. And when you draw that line, now depending on the kind of equipment you're using, some equipment use this kind of calipers, can draw a circle and then give you that line, and then it automatically computes for you the percentage, what they normally call DD ratio or DD percentage. In this very one, they use the A and B. But basically, A is the distance from the baseline, or the line through the iliac, the lateral board of the ilium to the posterior surface of the femoral head, and then the B is the distance, or let's say the diameter of the femoral head, but from the lateralmost part to the medialmost part of the femoral head. So when you divide, it should give you a 50%, at least in a normal hip, should be 50%. So the common one that I've seen, they use the DD, but of course the principle is the same. So whether it's AB, DD, really the principle is the same. And in this subject of mine that I scanned, I tried also to obtain that in the left hip. And in the left hip, I was getting a DD of 78.55%, which is really normal. And in the right, I was getting a DD of 75.48, which was also normal. And of course, yeah, the alpha angles were also 76 in the right and beta 41, which is within normal ranges. So there was really no need to worry. By the way, my subject was a male, 6 weeks old. Had really no complaint. Just did it for presentation and safe. So this is an example where we have an inadequate coverage. We have inadequate coverage. You see first of all, visually, you can see that this head is really less than 50% covered into the acetabulum. You see our ischium was kind of cropped off down here, but this ischium is down here. You have the hypoechoic pulvinar, hypertrophied teres ligament, and the fibrofatty tissue. Still a bad prognostic finding in such hips. And then when you look at our bony rim, not too bad, but not the best, not that angular. It's kind of, you can even see it's kind of shallow, and there's some little deficiency of the bony roof. So in case you measured this, definitely it wasn't measured, but definitely this would give less than 50%. So we would know that this acetabulum is inadequate. And that is the whole basis of the Tagisen or the Morin Tagisen kind of evaluation. So after diagnosing the DDH, what next? Of course, we need to manage, because we don't want, we said all we are avoiding is getting early onset of osteoarthritis in these hips. And the management, the earlier the baby or the infant presents for management, or the earlier they are diagnosed with DDH, the easier the management, the safer it is, the less invasive, and the higher the chances of getting the required outcome. So with age, as age increases, you get worse outcomes with the management. And it is believed that at around 8 years and above, the complications someone might get from the treatment might have a might lead to a poorer outcome than when that patient was actually left alone with their DDH, maybe to wait later on in life to deal with the osteoarthritis or the osteotomies, whatever. So you see that as long as you delay, when you delay the diagnosis, you're making the cases complex. And of course, when diagnosed early in the first 6 months, they always go non-operative kind of management using the abduction splinting. Remember the goal, we said the head is out of the fossa. So when they brace the child, like this is the pelvic harness splint. Excuse me, this would be the anterior view and this is the posterior view. The aim is having these hips abducted at a certain angle so that the heads can stay into the acetabulum, and then they stimulate the acetabular fossa to grow and be adequate, and then end up with a normal hip joint later on. So that's the goal. And they use that. Of course, there are some other bracings that are not so common, but the most commonly used one is the pelvic harness. That's it's not the only kind of bracing. And then, of course, sometimes they use closed reduction and speaker casting. This also, before the advent of ultrasound, they would use arthrograms to evaluate the effectiveness of the treatment with people with closed reduction and the speaker kind of casting. And in case of late presentation, or then they go operative, where they do the open reduction with speaker casting after, or they do open reduction and femoral osteotomy. Of course, we don't really want to get these levels of osteotomy. Or they do open reduction with pelvic osteotomy. Now that is with advanced age and advanced grades of the DDH. And of course, when we are scanning, definitely we have some pitfalls. The number one is when you don't get your alignment of the probe well, you won't get the optimal image. So you won't be able to assess optimally as you ought to. And then when you have older patients that are older than 6 months, of course, you can see these images, different images of babies at different ages. You have no ossified nucleus in the femoral head. As you go on, the ossification starts, and with age, this probably was around 7-8 months, and you can see there is really ossification, and the shadow is preventing you from seeing what is really down here, so you can't make proper assessments. And then some children who have hip flexion contractures, of course, probably they cannot attain the neutral position, or you may not be able to do your otolani and balo maneuvers. And then some children that have proximal focal femoral deformities, there can be an absent proximal part of the femur. It can be absent, or it can be deficient, and definitely you won't get a good landmarks for you to do your evaluation. And then some children will have the coxa vara. Oh, that's where you have, you see that the femoral shaft and the femoral neck should make a certain angle. So in coxa vara, that angle is reduced to below 120 degrees. So when you place your probe on the lateral aspect of the baby's thigh, actually the part that you should be sitting on the ilium will be in space. So it will be very hard for you to get that ilium as straight as possible for you to do your measurements. And those were some of my references, and thank you for listening. Back to the moderator, Christine. Christine, the moderator, please, you can come in, come the end of my presentation.
Thank you. That was a very detailed explanation on a very interesting topic. We'd like to open this platform to questions. Does anyone have questions for Mr. MJ regarding his presentation, his very detailed presentation? Thank you so much for that well put together presentation. We can see that you put a lot of work into it. So at this moment in time, we're opening the platform for questions and answers. You can just raise your hand if you've got a question for Mr. MJ. All right, this is the platform to ask if you've got any questions.